So thank you, Emily. We're excited today to have one of our graduates back. Dr. Aarti Bhatt is a graduate of the MedPeds program who's now practicing at Cook Clinic, and Dr. Bendel will introduce her more formally. Certainly the COVID crisis has merged with our health disparities issues to really create an almost perfect storm of problems for some of our most vulnerable populations. And our understanding of that is really important. So with that, I'm very glad to have Aarti back for the grand rounds, and thank you to Dr. Bendel for organizing this. I'll turn this over to Kathy, so thanks.
Thank you, Joe. I appreciate that. I'm Kathy Bendel. I'm the Associate Chair for the Department for Equity, Diversity, and Inclusion. And I'd like to welcome everybody today to the first EDI Grand Rounds for the 2020-2021 year. I kind of stumble over all those 20s sometimes when I say that. It is our I just wanted to remind everybody, because we have a lot of new faculty members, that our Equity, Diversity, and Inclusion Council is always looking for members. So if anyone is interested in joining us, please contact me. And we have a number of exciting initiatives coming up this year, so look forward to some emails in the next few weeks to months. And there'll be lots of things that people can get involved in if they choose so. It is my distinct pleasure to welcome one of our own, Dr. Aarti Bhatt. As Joe said, she's an assistant professor in internal medicine and pediatrics, trained here at the University of Minnesota, where she also completed a chief residency year in global health. I can remember quite a few nights in the NICU workroom or weekends having interesting discussions with Aarti about a variety of topics. And health inequity was one of those that we discussed in those days. She currently works as a primary care physician at Cook, as Joe mentioned, which is a fabulous place if anyone hasn't been there. It's actually my own primary care place where I see physicians. She's an active member of the Social Medicine Consortium and does community organizing throughout the Twin Cities campaign against racism. And she is also on the board of the Minnesota Doctors for Health Equity, which is an amazing group. She's one of the early founding members, and they've really done some amazing work here in the cities to kind of move the needle forward here. So I send you updates on their work periodically, but I'd like you to pay attention when you see those emails. Aarti has a particular interest in narrative health and community-centered approaches towards dismantling systemic racism as a social force that drives health equity. And so she's here to talk to us today about illuminating inequity, how COVID-19 magnifies pre-existing health disparities. Welcome, Dr. Bhatt.
Thank you, Dr. Bendel and Dr. Bowman-Chope and Dr. Neglia for having me on today to talk. So we're going to be talking today, yes, about structural racism and COVID-19 and how some already existing health disparities and health inequities are being magnified through the lens of this pandemic. I just want to say before I start that I approach most things with humility and acknowledge that we're always learning, and I'm curious to hear from all of you as well, either through the chat or afterwards, just about your thoughts and your experiences as well. So I'm going to try to advance my slides. There we go. All right. Just start every talk by doing a brief land acknowledgement and just acknowledging that the land on which we gather, no matter where you are, Dr. Borman-Chope pointed out to me too, is that it's seized territory. The land that I'm on is seized territory of the Dakota people. And also just acknowledge that simply doing a land acknowledgement is not enough. I also just want to take a moment to remember, especially, you know, being that we're situated here in Minnesota, a moment to remember George Floyd, Breonna Taylor, Dominique Clayton, Rayshard Brooks, and Philando Castile, and many, many, many other people who have been victims of police violence. Just a disclosure side, I don't have any financial disclosures. All the images that are used in my talk are provided with permission, are attributed or open source. And just to say that what I'm going to talk about today, there's a lot of content, but this is just a brief overview of this content. I want to acknowledge Dr. Nathan Chumlo, Dr. Beth Rogers, Dr. Sakina Naqvi, and the Social Medicine Consortium Campaign Against Racism. All this work that I do in health equity is part of a village of people who are working together and supporting one another. So just some objectives. Discuss how structural racism has led to disparities, in mortality and morbidity from COVID-19, illustrate the disproportionate impact of COVID-19 on Black and Native families and communities, as well as the impact on some non-Black and Indigenous people of color, and consider actions that you can take to dismantle structural racism, given that it's a public health crisis. You may know that the House of Minnesota just passed a resolution stating that racism is a public health crisis and a cause of health inequity. Things that I'm not going to be able to cover in depth, but recommend that people just become familiar with is just racism, medical history of racism, racism in medicine, race-based medicine, microaggressions, stereotype threat, white privilege, white fragility. So we're going to be talking about COVID-19 today, and I just have one brief slide about the 1918 influenza pandemic, because we're talking about disparities in during the time of a pandemic. And then the 1918 influenza pandemic is just a good example of how this isn't the first time that we're experiencing anything like this. The bubonic plague was also another major pandemic that illustrated similar themes. But the 1918 influenza pandemic infected 500 million people, almost a third of the world's population, killed 50 to 100 million people. And and in the backdrop of the influenza pandemic in the US was an epidemic of anti-Black violence, segregation, white supremacist ideology. Interestingly, African Americans during the 1918 influenza pandemic had a lower incidence that was documented, but a higher case fatality. W.E.B. Du Bois in 1900 analyzed the census and saw that the Black death rate was greater than the white death rate in general from disease by 69%. And African Americans were dying at a 2 to 3 times higher rate than white people from TB, pneumonia, and diarrhea. A lot of this was due to structures that were in place, restricted access by Black patients and health professionals to healthcare facilities, racist scientific theories of African American inferiority. Black people in the United States at that time lacked political and economic power, lived in neighborhoods that had lower resources. But also, just despite this, there was a big movement where African Americans created separate hospitals, facilities, and organizations to take care of themselves, which proved essential due to the rigid racial barriers in medicine and public health at that time. The other thing is, especially right now, when there's a lot of rhetoric around sort of blaming others for the COVID-19 pandemic, and something like that was also present during the Spanish flu. The name Spanish flu is actually quite misleading, and it's sort of part of this time-honored custom of trying to blame an other for the spread. So in Senegal, they were calling it Brazilian flu, and in Brazil blamed Germans, and Poland blamed Bolsheviks, and Persia blamed British. And so when you hear things like the Chinese virus, for instance, in reference to COVID, understand that this does not imply, or it shouldn't imply, that we're blaming a group of people for spreading this virus, although that is the way that language is being used inappropriately and in a discriminatory way. And there's precedence for that in history. So just to move on then, I'm going to just take a few seconds to just talk about where we are today as far as total number of cases. So worldwide cases, and this is as of yesterday, 16.5 million cases worldwide with 654,000 deaths. And if you haven't visited the Johns Hopkins University Coronavirus Resource Center, it's a really, really great resource for just understanding where we are epidemiologically right now. In the US, 4,390,000 cases with 151,000 deaths. And the Johns Hopkins Center actually has some really great graphs that show what the situation specifically in Minnesota is like. Right now in Minnesota, we have a total of 52,281 cases and 1,580 deaths among cases that are, 1,580 deaths total. So this, basically what this slide is showing is it's just showing the total number of cases. And I know it's kind of a busy slide, but you can see in the legend there that they have different colors that correspond to when restrictions or like shutdowns were put in place, when reopening started, and correlations with spikes in cases around that time. This particular slide is just talking about new deaths. And the reason that I actually brought up these two slides was not necessarily to go into them in detail, but more to say that these types of data we see a lot of, and they don't tell the whole story, right? They talk about broad numbers of cases, and they do make correlations between specific interventions that we've put in place to try to keep people safe, but they don't tell the story of the disparity that we're seeing. And that's what I want to talk about today. So I'm going to switch gears, and we're going to talk a little bit for the next few minutes about structural racism. I personally can't talk about structural racism without acknowledging Dr. Kamara Jones. Dr. Jones is a Radcliffe Fellow right now at Harvard University. She is a senior fellow at the Satcher Health Leadership Institute. She is the former past president of the American Public Health Association. She's an adjunct professor of community and preventive medicine at the Morehouse School of Medicine. And she is a senior mentor to the Campaign Against Racism and has been doing work in understanding how structural racism policies and the structures of our society have been leading to health inequity for Black, Indigenous, and people of color in the United States for a very long time. She used to work for the CDC and actually she left the CDC about 14 or 15 years ago due to pervasive racism in the CDC, which has been in the news recently. So Dr. Jones has a definition of racism that I really encourage everybody to read about and internalize. She talks about racism as a system of structuring opportunity. So it's a system, it's something that's built, and assigning value based on the social interpretation of how one looks. And that's what we call race. So there's a few really important points there, is that one, that it's a system, it's structured, it's intentional, and it assigns value based on the social construction of race. So in that one sentence, we're talking about the fact that race is not a biologic construct, that's a social construct. And this system unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through a waste of human resources. Dr. Chumlo shared this slide with me that just and I'm sure many of you have seen it before, talking about how racism as the system is just an iceberg, and what we oftentimes see are these interpersonal manifestations of racism. So we see explicit and visible acts like Charlottesville, or white supremacists marching, or people saying mean things, or maybe even microaggressions, but below the surface we see the structures of our society, things like historical redlining and housing discrimination policies, the way that our carceral system is set up, biased immigration laws, the war on drugs, gentrification, underrepresentation in politics, all of these other types of somewhat invisible forces and policies that actually is the reason that racism persists. And the vast majority of racism's power is baked into the structures and systems that we all participate in, and it's important to acknowledge that. So making the invisible visible, I think that there's a lot of us, and probably many of you on this call today, who have known that racism is a problem in Minnesota, it's a problem in our society, it's a problem globally that's led to inequity far before COVID-19. And some just examples of that we all know, especially from a pediatrics perspective, is that we know that personally experienced racism in health, and Dr. Jones has talked about this a lot, is that the chronic stress and experience of racism over a lifetime for Black, Indigenous, and Hispanic people, as well as other groups, leads to health outcomes that are not good. Lower birth weight in babies born to Black, Hispanic, and Arab American mothers who experience discrimination, increased risks. Many of you are probably familiar with the ACEs study that the CDC did, showing that adverse childhood events increase risk of depression, obesity, insomnia, lower self-esteem, poor overall health, and that exposure to racism in adults has led to increased risk of heart disease, depression, and other ailments. These are things that we know. And Minnesota is not immune to the effects of this racism. We might hear in the news about the individual instances that are happening where that you might see in the Star Tribune, St. Paul school staffer on leave after saying racist remarks, or you know, we definitely have an issue nationally and locally with the way that children are disciplined based on the color of their skin. But also there are health inequities associated with that. And we, as a state, we have some of the worst health disparities between white children and Black children in the country. Rates of asthma in Minnesota are 12 to 14% in Black children compared to 6% in white children. A death rate from asthma in children is also significantly higher in Black children as compared to white children. And I think it's just important that studies have shown recently that this is not related to some kind of genetic factor, that zip code, living conditions, poverty and segregation, and environmental racism lead to environmental racism as a structural factor that causes these disparities. So it's something that we need to acknowledge and we need to think about in our work to dismantle it. My particular, here, sorry, I didn't realize I forgot to advance this one part. You know, one of the areas that I do organizing around is in housing, in racism, and I would really encourage you to visit a few websites. One is called mappingprejudice.org if you haven't had a chance to visit it, and the other one is the Wilder Foundation. Mappingprejudice.org is actually an organization that is run by historians who've looked through Hennepin County, and I think now they're actually working on Ramsey County to look through housing deeds from the turn of the century, where there were very, very specific phrases in the deeds called racial covenants, which said that people of only Caucasian race were allowed to obtain mortgages, were allowed to lease land. And racial covenants led to redlining, which created intentional segregation in housing policy. And one of the manifestations of that you can see that's very, very visible is in homelessness. And the Wilder Foundation has a lot of data around homelessness in Minnesota. And I think this is really pertinent, especially right now when we're talking about COVID and the sort of epidemic of homelessness that we're seeing in the Twin Cities. But 38% of homeless adults are Black and African American. And the percent of all Minnesotan adults that are Black and African American are 5%. So disproportionately, we're seeing higher rates of homelessness in Black and African American populations in Indigenous populations as well. And children and young adults are also being affected by this. My clinic was across the street from where the Hiawatha encampment was last year, and there were large numbers of children and young adults who were living in those encampments as well as currently in the encampments that are in Powderhorn and some of the other sanctuary sites in the park. So again, these are just, I put those slides in to briefly say that, again, Minnesota is not immune. We've been seeing issues with structural racism in our society for a long time here in Minnesota. And so I just want to, again, ground us in this as we move on to talk more specifically about COVID-19 and disparities, to ground us in this understanding of racism as a system that was already in place and leading to inequity before this pandemic started. So back in April, which is like the first time that I started talking about this, I read a really great quote that just said, while COVID-19 is indiscriminate in its transmission, its propagation within a society steeped in structural racism will undoubtedly, as we are already beginning to see, lead to disproportionate impacts on our marginalized racial groups in this country. And I remember one day sort of like opening up my news feed and just seeing all of these headlines sort of thrown at me. And this was back, a lot of this was back in April when some health departments started around the country. Minnesota didn't have this type of data yet at that time, but started documenting that undocumented farm workers, essential workers were being disproportionately affected, that African Americans were being disproportionately affected by COVID-19, getting sicker, and Indigenous folks and homeless individuals were at very, very high risk, which we all know. This is one of the most, I apologize for the quality of this slide, but I found this to be one of the most compelling like images that I've actually seen back from April when I had attended a talk that was talking about the percentage of population of African Americans in these different areas, different cities in the country, and the percentage of deaths back at that time. I mean, I lived in Milwaukee for 8 years. It's one of the most segregated cities in the country. 26% of the population is Black, but even at that time, 73% of the deaths were in African Americans in Milwaukee, and the same was true in Chicago and Illinois. And so at that time, you know, we didn't have this type of data for Minnesota, and I think that some people that I talked to were like, well, this isn't happening in Minnesota. Well, it's definitely happening in Minnesota. And if you can go to the Minnesota Department of Health's website, I think this is a really sobering graph. If you go to the Minnesota Department of Health's website and go to the COVID weekly report and go to slide 11, it's the same every week. They do age-adjusted rates. So this is the cumulative case rate, which is the number of cases by race or ethnicity per 100,000 people in Minnesota. And I think the really compelling and important part of this is we're looking at the disproportionate impact in Minnesota that COVID-19 is having on Black populations, on Indigenous populations, on Latinx populations, on Native Hawaiian and Pacific Islander populations. And if you look at the colored bars below, the blue bar talks about cases hospitalized. So again, these are the adjusted cumulative case rates based on proportion of population. You're seeing a much higher rate of hospitalization in Black people in Minnesota, and a higher rate of death compared to white people, even though there are by far more white people in Minnesota than there are Black. So again, we can't ignore this here. And just before we started, Dr. Negley was talking about, and I don't have a lot of specific pediatric data, unfortunately, I wish that I did, but how just anecdotally, you might be seeing that as well in the hospitalized patients. So again, why is COVID-19 ravaging Black America and Indigenous populations? Why is it affecting homeless folks? Again, I just want to ground us in this idea that systemic racism is a huge factor that plays into why we're seeing the disparities that we're seeing right now. There's this activist and artist, her name is Danielle Koch, who drew this beautiful drawing, kind of beautiful and heartbreaking drawing about why it is. But if you're more of a visual person, again, think about systemic racism as the soil, as the roots of a tree that then lead to all these different types of disparities that then branch out into creating higher risk for contracting and dying from COVID. So again, you see, because of systemic racism, and one of the things that I like to say is there's a really big distinction between systemic racism and social determinants of health, right? So I think about social determinants of health as sort of the conditions where we all live and work and play, and racism and sexism and all those sort of the isms that we see are sort of the social forces that create those conditions. So we're really looking upstream here. And so, you know, what we see is we have, you know, systemic racism that's leading to disproportionate incarceration of Black people in prisons. Prisons are overcrowded, and I have a slide about that in a second, about how, you know, prison populations have a much higher rate of COVID-19, and there's been outbreaks in prisons all across the country. Housing discrimination is a big thing, and in Minnesota, we're seeing a lot of that right now, partially because of the history, like I said, of racial covenants and redlining, housing discrimination, inability to get a mortgage. More Black people are living in urban areas, closer together. It's harder to do social distancing. They tend to be essential workers. It increases COVID risk, having to use more public transportation. So there's multiple issues. For pediatric populations, educational disparities are also something that we have to think about and take into consideration, especially right now when we're having the conversation about schools and reopening. So how are some ways that we are, in general, have been perpetuating inequity through the COVID response? So I'm just going to go through a few things and give a few specific examples. So I think that, again, this pandemic hit, the underlying disparities were already there, and then there was the response for how we were going to address this pandemic. Very initially on in the pandemic, we did not have adequate access to testing, and there was inequity in who was able to have access to testing. I know at the Coop Clinic, only recently has Minnesota Department of Health prioritized community health centers as primary testing sites for COVID-19, acknowledging that the patients that we see, which are predominantly, at my clinic, we see a predominantly Somali population, immigrant, refugee, Latinx, and also African-American population were being disproportionately affected. So that was one area that I think has perpetuated the inequity currently. So early testing and also contact tracing and all that stuff early on. Again, ability to shelter in place, so links to homelessness, rates of home ownership. So rates of home ownership are very, very closely tied to structural racism and housing policy. A lot of people have minimal economic reserves secondary to barriers and access to employment. And that kind of ties into who are essential workers and who are the people that are in situations where they don't have the luxury maybe necessarily to work from home. Decreased healthcare access and inequity in telemedicine. I have a few slides on that coming up. For communication to low English proficiency communities. I think there was, sadly, I think that maybe we didn't all do a great job of communicating, and partially because there was a lot of unknowns about COVID earlier on, but communicating to different populations who are non-English speaking about understanding COVID, about understanding risk, about understanding social distancing, I have had several patients in clinic who are non-English speaking patients who actually were under the impression that they were not allowed to let their families or their children leave the home. And I had a dad the other day who said, my children haven't left the home and like they haven't been outside of the house in 3 months. So even just that type of communication and how it can affect the mental health of children and families is important to think about. We're continuing to deport people and detain people in detention centers, which has, one, spread has been increasing of COVID in detention centers, but as well as the fact that we're actually exporting cases of COVID to other countries that have a lot fewer resources. And then there's other collateral damage for the people who are being hospitalized, which are disproportionately Black and Indigenous people of color and other people of color. You know, there's just the collateral damage of what does being hospitalized in isolation, how does that affect your mental health? In general, access to healthcare, how are people's chronic diseases and or previously underlying diseases being managed in the time of COVID? I know pediatric visits have been a huge thing. We have data at Kook that showed that our pediatric visits went way down after COVID, and we still have a lot of families that are very, very hesitant to bring their children in, so they're getting behind on vaccinations. So there's a lot of things to think about. Just to draw your attention to some of these issues in a little bit more depth. You probably have all heard about the Powderhorn encampment that recently has sprung up. So I think that from a structural standpoint, thinking about what we talked about earlier, the already existing disparity in homelessness and the epidemic of homelessness that was already existing in Minnesota, now we have an issue where, you know, people have to still potentially pay their rent. The moratorium on evictions is closing. The number of people who are homeless in our cities is increasing. And, you know, from a structural standpoint, we really need to think about housing as health and how are we going to prioritize that? One, to protect people from COVID, to not increase disparity further, but also to address sort of the history of structural racism in housing in our cities. Dr. Pandita, who is also on the board of Minnesota Doctors for Health Equity, and she's the CHIO and the program director of Clinical Informatics Fellowship at Hennepin County Medical Center. She recently wrote an article talking about telehealth, health inequity. And she said our own data at Hennepin Healthcare shows that while 35% of our patients identify as racial and ethnic minorities, only 8% of these groups are participating in telemedicine. I can say at Kook as well, anecdotally, we're seeing the same thing. And she names a few of the issues: limited English proficiency, lack of digital access, lack of trust. She said that, and it's documented in the article too, that what they found with community surveys has been that a lot of the Latinx population has fear, justifiable fear in the setting of continued ICE raids and deportation, of being potentially videotaped and what that could mean for their health and their safety. She talks about the importance of data-driven health systems, that all health systems need to be collecting data regarding race, language, and ethnicity, the importance of community needs surveys, and the importance of the advocacy around, you know, broadband internet access for people. She sent me this data, which I understand is an extremely difficult slide to read, but I'll just point out the colored boxes. So on the left-hand side of the screen, they have some data, and this is through Hennepin Healthcare, just about like generally demographic makeups of people who are coming in for visits pre-COVID, and then the demographic of people who are engaging in telehealth visits between March 1st of 2020 and May 23rd of 2020. That's the most up-to-date data that she had. And what you can see is that On the left-hand side, you know, the light blue box, for instance, was the Hispanic and Latinx population who was engaging in care, kind of in healthcare prior to COVID. And now you can see how that light blue box has gotten a lot smaller, right? The yellow box is white, identifying people who are using video and telephone visits, the sort of like the bright yellow and then the pale yellow. So the people who are predominantly engaging in telehealth are people who were already privileged before, probably already had better internet access, were not already being disproportionately affected by COVID, and have higher English language proficiency. So that's just the takeaway there, that there's definitely an issue with inequities being perpetuated in the way that we're doing telehealth. The carceral state of our country, the sort of history of mass incarcerations, the history of privatization of prisons, is definitely showing us the impact as far as infection rates in incarcerated populations. And again, disproportionately, people who are incarcerated are people who are Black and brown folks, and the reason for incarceration is disproportionately related to minor offenses. And so this again is related to upstream factors of systemic racism. Dr. Sakina Naqvi actually had shared some of this data with me about how in other countries, like in Turkey and Iran, they're releasing tens of thousands of prisoners from jails, and as a way to help reduce the spread of COVID-19, people with minor offenses. And many Western democracies have really dragged their heels on doing that. In the UK had plans to release up to 4,000, which is 5% of their prison population, but actually they have not been doing that as much. But the infection rate in the United States is 2.5 times higher in prisoners. More than 35,800 prisoners and staff have contracted the infection, and 8 out of the 10 outbreaks in the country since, you know, some of the major outbreaks have been in prisons. And so again, thinking about the incarcerated population at a time like this is also really important. Another area that I wanted to focus on is the essential workers. The ACLU in Boston actually did some really, really interesting mapping work, and I wonder if they've done it in Minnesota, and I just haven't seen it as well. But they found in Boston that essential workers, based on their mapping, and essential workers are not just healthcare workers, right? But they're the people that are working in grocery stores. They're the people that are working as migrant laborers, farming. They're the people that are working, driving trucks and in warehouses. And so they were most concentrated in these very specific areas in Boston, Dorchester, Roxbury, and East Boston, which was, again, the same neighborhoods where the virus was present at its highest rates. And when they overlap those maps with some ethnic and racial data, they found that those same areas were also predominantly where people of color were making up the majority of the population. So essential workers are at high risk. And what I will say is that in our response, we were woefully inadequate in making sure that essential workers, one, had the protections they need, two, that they had proper, personal protective equipment, that people were getting, compensated appropriately. We don't have a living wage. We don't have paid family leave. So all of these kind of more upstream things are also affecting the risk that essential workers are having. And a lot of the essential workers in Minnesota and around the world are Latinx folks. And we're seeing, especially even right now, that the disparities are really, really increasing. I've had multiple Latinx entire families who've come in all testing positive for COVID. And a lot of that has to do with these types of underlying disparities: lack of access to healthcare, uncontrolled chronic conditions, multifamily housing, if undocumented, cannot collect employment are sort of forced to work and are working in low-paying service jobs without adequate protections. And so from a pediatrics perspective, when we talk about COVID, while I know a lot of the data I'm presenting is in adults, this is affecting families, right? It's affecting entire families of people, and it's happening disproportionately. There's just some other areas that have really recently documented. Oregon Health Center clinics, Latinos have 20 times higher positive rate than other groups. In Iowa, 20% of the COVID cases, 6% of the population. In Washington, 30% of the COVID cases, 13% of the population. Florida, 50% of the cases, 25% of the population. So we can't ignore these types of statistics, and we do need to address them when we're talking about health disparities. There's been a lot, and maybe you've read in the news about meat packing plants and how COVID has been sort of ravaging through meat packing plants. As of June 8th, there have been at least 23,500 reported COVID cases that are directly connected to meat packing plants in at least 232 plants in 33 states, and multiple deaths that have been reported. There have been private contract tracing companies who have not been collecting appropriate data. They were missing phone numbers for contact tracing. So even in just how we're doing contract tracing in these really, really packed environments, social distancing is virtually impossible in a modern meat packing plant. So it makes an ideal environment for the virus to spread. And if you think about, again, the upstream policies, in recent years, meat packers have successfully lobbied regulators to increase line speeds, with the result that workers must stand shoulder to shoulder, cutting and deboning animals so quickly that they can't pause long enough to cover a cough, much less go to the bathroom without carcasses passing them by. Meat packers have lobbied regulators to do these things. Some chicken plant workers are given no regular bathroom breaks and have to wear diapers. So the working conditions of people who are essential workers is in many cases abhorrent. And we've seen this even in meatpacking plants in Minnesota where we've had increased outbreaks. So as the meatpackers push to keep their production line moving, they've ultimately even won over the nation's highest office, because in late April, our president issued an executive order to put federal muscle behind ensuring meat processing plants could remain open. In emails, local health officials expressed frustration that it would only embolden the companies to ignore their advice. One Kentucky health director that was faced with repeated reports that Purdue Farms was pressuring sick and quarantined workers to return to work wrote, "My guess is they will force them to work," citing the presidential order to stay open. So people are at high risk, and all these things are going on. And then one other slide about this particular population is just in relation to immigration policy and COVID-19 and ICE raids. So some of the data that I've come across is that in ICE detention centers, there's been a 50% positivity rate for those tested. And of course, upstream policy in March 20th, there was a ban and suspension on people who were seeking asylum. And I think that what instead we should be thinking about social distancing during border processing and how we're going to actually do that, allowing asylum seekers to wait for court hearings with families and other U.S. contacts through parole, transferring unaccompanied children to reunite with their families, facilitating self-quarantine at destination locations. But that's not what's happening, but that is what the WHO and the UN Refugee Agency and other UN agencies are suggesting that we be doing, which we are not. Sorry, I know there's like a lot that I'm going through here. I know that there's populations that I'm not addressing, but I'm trying to sort of give a very broad overview. And I want to sort of wrap up here with talking specifically about the Indigenous community. I think that the Native American community has been historically neglected by the US for years. We know that the IHS The Indian Health Service is chronically underfunded, and there's been multiple reasons for that. But these are populations that have undergone genocide at the hands of sort of American expansion, capitalism, and colonialism, and now are being hit hardest by the COVID-19 pandemic. I would encourage you to read some of the work that Rebecca Nagel has written. She's a, I believe, Cherokee activist and writer, and she talks about how Native Americans experience diabetes 3 times more than any other racial or ethnic group in the United States. They have high rates of asthma, and already health systems were underfunded prior to COVID-19. This is a really just compelling quote that I saw. "We are a small population of people because of genocide, no other reason," said Echo Hawk. "If you eliminate us in the data, we don't exist. We don't exist for the allocation of resources." And we've definitely been seeing that, especially early on in the pandemic. There was not good disaggregated data from many health departments. A lot of Indigenous and Native folks were being put in the other category. And what we see when we don't have good demographic data about who's being affected, what happens is that when we talk about upstream allocation of resources that are coming through CARES Act and resources from the federal and state governments, they don't get adequately allocated to Indigenous populations. This is just actually a very recent article that came out, in a perspective piece in the New England Journal of Medicine, that was talking about the situation in Navajo Nation. Through the Campaign Against Racism, I've done work with colleagues in Navajo Nation, and it's definitely being hit very, very, very hard right now by the COVID-19 pandemic. And a lot of times, like, we talk about the issues of there isn't even adequate access to clean drinking waters. Again, health systems have been chronically underfunded, and there's already high levels of chronic disease. And so there were some people in Navajo Nation who were just reflecting on the situation, saying, "I don't know what will come next. A month ago, our first cases alarmed us. A week ago, our hospital was at surge level 3. A series of tarps separated our COVID ward from the rest of the hospital. Now we are at a level 5. The whole hospital is the COVID ward. At level 6, we may expand to a school gymnasium. By the time you read this, everything will look different, but it won't be over. The news cameras will have gone, but we will still be here." And I think that it's really important to be centering the narratives of the people who are predominantly affected by health inequity and COVID-19. So what can we do? So I've presented a lot of data. We've talked about a lot of the different disparities that are existing right now and are being magnified by the COVID-19 pandemic that are very, very specifically related to structural racism. So I just have listed a few things here. It's definitely important to stay informed. And like I said, I think it's really important to be informed by the people who are, I guess, center the margins, who are predominantly affected. I found that the African American Policy Forum under the Blacklight series has been one of the absolute best resources. They have it's run by Kimberly Crenshaw, who actually coined the term intersectionalism, talking about how intersectional systems of oppression affect people. And I strongly encourage people to check it out. They have weekly webinars as well as a podcast. And then in Minnesota, there's actually this Facebook series called We Good, While Black Minnesota is vulnerable to COVID-19. That's worth checking out. Some of the organizations that I'm involved with, Minnesota Doctors for Health Equity, I think that, one of the takeaways that I've had in doing health equity work has just been that it's, our job as physicians goes outside of the clinical exam room. We're advocates for our patients, and we have to think about ideas like housing is health. Inadequate housing means that our patients can't be appropriately healthy, and our job is to make sure that they're the healthiest they can be. So being also a citizen professional as well as a clinician is important, and I just encourage people to do something, whatever you feel like you're able to do. There is an email for Minnesota Doctors of Health Equity right now. Our sort of areas of focus are around housing justice and then voting, voter registration, and telehealth equity. The Minnesota campaign against the Twin Cities campaign against racism is more local grassroots community organizing. And we've been doing a lot of work specifically with organizers that are working in the homeless encampments and centering the narratives of people who are experiencing homelessness and challenging sort of the state legislature for more resources for sustainable housing. And then I also add this book, My Grandmother's Hands by Resma McKenna, which is, I would say, part of the internal work that we all also need to be doing when we talk about racism, is reflecting on our own implicit biases, reflecting on the way that racialized trauma has affected all of us, how whiteness has affected us as well, because ultimately our systems are made up of people. And so we all need to do that individual anti-racism work as well so that we can be part of the solution. Minnesota Doctors of Health Equity talks a lot about too, just like the levers that you can get involved with. So there's like I said, the individual, the system, the community, and the government. So there's so many ways that you can get involved, from volunteering or doing more community-based grassroots efforts to thinking about in the system, the institution that you work in, how are people prioritizing equity in all policies, and how are those policies being informed by the community and the people who are closest to the inequity and whose lived experience we must honor when creating policy. I'm going to leave some time for questions, and so I'll just end with some of my favorite quotes. Angela Davis says, "In a racist society, it's not enough to be non-racist, we must be anti-racist." And Sonia Renee Taylor, who is a African-American queer sort of womanist theologian, has done a lot of talking about the opportunity we have right now to create and reimagine the systems that we're living in. So she says, "We will not go back to normal. Normal never was. Our pre-corona existence was not normal, other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not long to return, my friends. We are being given the opportunity to stitch a new garment, one that fits all of humanity and nature." So I wanted to sort of end on an uplifting tone about that, you know, there are things that we can do to address some of these upstream impacts. So at that, I'll leave it open for questions. I have not been paying attention to the chat, but I don't know if Dr. Borman-Shope or Dr. Bendel, if there are questions that came up.
Looks like we did. Thank you. That was exceptional. What a great talk. Dr. Schleiss asked if you have any comments on school reopening and how to put the educational disparity issues into context with the COVID disparity issues that we just reviewed.
Well, I think that's a great question, and I wish that I had a better answer. I think the school reopening issue, and I'd love other people's thoughts on that, is one that there's so many factors to weigh, right? I know that the AAP did put out a statement about encouraging school reopening. At the same time, I don't know that they really included the perspective of teachers and staff workers in schools and safety related to that. But we also know that, you know, being in school is really important for kids. And so I don't have an answer to that question, Dr. Schleiss. I wish I did. I think that this is one of the more complicated topics that we're dealing with right now in our state. But whatever they decide to do, I think that prioritizing social distancing and safety is going to be really important if people do decide to reopen schools. I think they're going to be announcing that this week, right? Is that correct?
Yeah, it's this week. I think there have been rumblings from different school districts, and yeah, I hope we will all brainstorm about that as a faculty, because I think some distance learning is quite likely, and how can you best support a family who doesn't have good internet access, or maybe doesn't have enough tablets or computers for people to use, or the parents aren't able to navigate the schoolwork effectively.
And I think that that's really where we need to think about is like, what resources do people need and how can we get those resources to people? So if there is a distance learning component to it, then state resources need to go into making sure that people have broadband internet access, people have a safe place. If people need tutors because their parents have to work because they're essential workers and they don't have the ability to stay home and homeschool, that those families get priority, right? The people with the highest needs should be getting the most resources.
I wondered if you could comment on testing and sort of safe places for COVID testing, if that makes sense. I've had some families where I sensed that they were concerned about engaging with the healthcare system and that was limiting them or a family member from accessing testing. Are there testing sites that some of our patients might feel more comfortable accessing?
I think so. I mean, I think that there are definitely, I mean, I'm probably biased because I work in a community health center, but I think that places that are embedded in the community and have relationships with the community are going to be safer. So, Minnesota Department of Health on their website has a list of like all the community health centers that people can go to get tested. And so I oftentimes will give that to people as a resource. And so, that in the Minnesota like community care hospitals that are in St. Paul have really great resources and are very, very, especially the Spanish-speaking community in St. Paul are very sort of tapped into that community and embedded in the community. And so I feel like that is a safe place for a lot of people to go. We've been having just, huge numbers of people come through Kook for testing. But there is still, people have a lot of questions. They have a lot of concerns. And, there's a lot of concerns. There's a lot of questions too about if it's even it's gonna cost people money, because testing is not free right now, especially if you're not uninsured.
Yeah, thank you. Looks like we've got another kids here. This one is from anonymous attendee. Kids are given iPads by the schools, at least in St. Paul and I think Minneapolis, but they have restrictions that prevent them from using them for virtual medical appointments. It would be wonderful if someone could figure out a way to collaborate with the schools so we could use school provided iPads for medical needs.
That is such a great idea. We've talked about that in Minnesota Doctor for Health Equity as well, is that how can we leverage already existing technologies that kids are getting to help improve interaction with the medical community. We've talked about, and I don't know, I think there have been some conversations about this, but I don't know if anything's happened with it, about utilizing library technology as well, like partnering with the library. I think that this is a really interesting time to sort of reimagine creatively how we can like de-silo ourselves and build coalition with other sectors to help improve health.
Mm-hmm. Someone updated, it's just St. Paul that has tablets. Minneapolis doesn't have that full budget for all kids to have them.
Bummer.
Well, I think we're just about at time, and I suspect that Dr. Bendel may have been called away to care for the tiny babies. But thank you so much. That was a really important and moving talk, and I think hopefully we'll all spend some time thinking about the small or large actions that we can all take, because this is not going to go away anytime soon, and I think it has really given us all a chance to examine what we can do as pediatricians and advocates for children. Thank you very much, Dr. Bhatt. That's great.
Absolutely. Thank you so much for having me.
It's our pleasure. Bye, everyone.